following in detail. So apoptosis results from activation of caspases. Yes, this is true. Okay. Intrinsic pathway is also called mitochondrial pathway. Yes, this is true. Pro-apoptotic family of proteins include BACs and BAC. Yes, this is true. Okay, so this extrinsic pathway can be inhibited by a protein called as FAD. This statement is wrong. It is not inhibited, but it is executed by this protein. Okay, there is a protein called as FLIP, and this FLIP is the one which inhibits it. Okay, not FAD. Okay. So moving on, let us just tell you what apoptosis is. Okay, so you have apoptosis, and this is what we were discussing about. Okay, so apoptosis. Okay, so when you have a cell, right? So this particular cell will undergo, whenever there is a injury to the cell, there is reversible injury, irreversible changes which takes place, and finally it proceeds for a cell death. Okay, so whenever there is some assault to the cell, it can reverse itself or reverse itself and proceed to cell death. Okay, now the cell death is either necrosis, apoptosis. You also have necroapoptosis. So all these are your basics. You are pakka with these, right? So our question was only concerning to apoptosis, which I'll be explaining in a little detail. Okay. So remember, apoptosis is a cell death, and this is also called as programmed cell death, right? So apoptosis is a programmed cell death. Okay, or it is called as a suicidal death program. Okay. So what happens in apoptosis? So when I'm saying apoptosis, okay, so does this normally occur in our body? Yes, apoptosis normally occurs. So when does there are apoptosis which occurs in physiologic state, and apoptosis also occurs in pathologic states. Okay, so you need to know this. Fine. So whenever you're reading pathology, why are you understanding pathology? Because you're implementing all these things to your medicine, to your clinical practice. So why? So pathology gives you an answer as to what is the pathogenesis, why is this happening. Okay, so if you read with that understanding, you'll never forget things. Okay, so this is something you have to read and learn when you're doing pathology, right? So let's come back. So I was telling you, so there is physiologic changes, physiologic apoptosis and pathologic apoptosis. Okay, so now physiologic apoptosis is when there is embryogenesis. Okay, some cells have to involute, so they undergo apoptosis. So embryogenesis is one example. Second, whenever there is sudden hormone withdrawal, okay, the hormones get withdrawn. For example, there is a lactating breast, and suddenly the woman weans, and there is stoppage of these hormones, and then those cells, the lactating breast undergoes apoptotic changes, and it becomes to a normal lobular structure, right? So the lactating tissue is withdrawn by apoptosis. Okay, so what are the pathological states where you find apoptosis? Whenever there is DNA damage. And how does this DNA damage occur? When there is radiation injury, when there is cytotoxic drugs, when there is viral viromes which come and then they damage the cells. So all these things lead to pathological states of apoptosis. Okay, so this is again very important. So we will now go back to the question, right? So we'll now go back to the question. So what was the question? All of the below are true about apoptosis except. So again, now with this understanding, I'll tell you more about this. So now apoptosis has two pathways. So apoptosis, I told you, is cell death. It's a programmed cell death. Now this programmed cell death occurs by two processes, which is called as the induction and execution. Okay, there is induction or initiation and execution. So these are the two processes. And how does this occur? Okay, this occurs by activation of caspases, right? Your caspases are the ones which get activated, and that leads to this initiation cascade. Okay, so this again is happens because of two pathways. You have an extrinsic pathway, you have your intrinsic pathway. Okay, fine. So you have two pathways here. You have an extrinsic pathway, then you have an intrinsic pathway. Now extrinsic pathway is also called as the death receptor pathway. Okay, death receptor pathway, and your intrinsic pathway is also called as the mitochondrial pathway, right? So there are two pathways here, death receptor pathway and mitochondrial pathway. Okay, so moving on to this, so the option said that mitochondrial pathway is, the intrinsic pathway is also called as mitochondrial pathway. So yes, that option is right. Okay, now moving on to this, you have death receptor and mitochondrial pathway. So let's discuss what happens in the mitochondrial pathway. Okay, what is happening in this mitochondrial pathway is, whenever there is a cell injury, okay, or whenever the microorganisms come, there is cell injury. So this leads to, in your mitochondria, okay, will release something called as cytochrome C. Okay, so once the cytochrome C comes out, this in turn will go and lead to catalyzation and activation of caspases. Okay, and these caspases will further go on to execute apoptosis. Okay, that is your intrinsic pathway, right? So next you have your extrinsic pathway, which is also a depth receptor pathway. Okay, so what is happening in your depth receptor pathway? You have something called as your tumor necrosis factor receptors, and you also have the Fas ligand. Okay, so all these two are present, and your FAD protein. Okay, so your FAD is Fas associated death domain. Okay, so this also goes and binds and helps in your extrinsic pathway, and this extrinsic pathway goes on to activate caspases again. Okay, so this extrinsic pathway will go on to again activate the caspases. Now once the caspases are activated, finally the execution pathway occurs. Okay, so let's go back to this. So apoptosis is by extrinsic pathway and intrinsic pathway, right? So you have these two pathways. So as already mentioned, so extrinsic pathway is also called as the death receptor pathway, and here you have your FAD. Okay, so in fact FAD protein will cause initiation and not inhibition. Okay, so it will cause initiation and help in apoptosis, right? So the intrinsic pathway, here there is an intrinsic pathway which occurs in the because of mitochondrial cytochrome C release. Okay, so this is called as the mitochondrial pathway, right? So some books also mention about another pathway called as a granzyme pathway. You just have to know that these are executed by the cytotoxic T cells. Finally, they also activate the caspases, but this is, you know, not very, like, it's not mentioned in Robin. So these are the two important pathways that you have to know, right? Okay, so ultimately once you reach the execution pathway, what is happening? How does the cell die? So once execution pathway, or once all the caspases are activated, you have caspase 8, caspase 9. So once these two are activated, caspase 3 comes into picture, and this causes endonuclease activation. Okay, so this endonuclease activation will cause degradation, and some enzymes get activated, and finally the cell which is available will undergo apoptosis. Okay, so this is the most important thing that you need to know about apoptosis. So another important thing about apoptosis is when your mitochondrial pathway is occurring. So I told you there is a mitochondrial pathway, right? So when your mitochondrial pathway is occurring, there are some pro-apoptotic proteins. So there are some pro-apoptotic proteins, okay, and anti-apoptotic proteins, and there are So these two things are very important with respect to apoptosis. You need to know these two things by heart. So what are your anti-apoptotic proteins and what are your pro-apoptotic proteins? Very important. So what are your pro-apoptotic proteins? You have your BAX and you have your BAC. Okay. And what are the anti-apoptotic protein? You have BCL2, BCLX. Okay. So these are anti-apoptotic protein. You also have something called as sensors of apoptosis. Okay, remember all these are your exam questions. So sensors are your BAD, your BIM. So all these are sensors of apoptosis, right? So when it comes to apoptosis, few things very important. Apoptosis results from caspases. Know your intrinsic pathway, know your extrinsic pathway, what is it called and how is it activated. Next, in your intrinsic pathway, you have pro-apoptotic proteins, anti-apoptotic proteins, know their names, and what are these sensors, also know their names. Then come to the extrinsic pathway, remember that it is because of the protein FAD. FAD stands for fast, so this is a death domain, okay. So this particular thing will cause your extrinsic pathway to occur. So it is not inhibiting it, but some viruses have something called as flip protein. So this particular flip protein, I have already told you, so this flip is one which is causing inhibition of the extrinsic pathway. So this can come as a question, right? So the correct answer here is D, which is a wrong statement. I hope all of you have got this. So we'll move on to the next question. Okay. Apoptosis, important. Apoptosis, necrosis, what are the differences? Now again, this is a PG and a PG exam question as well as your UG question. So you need to know what are the changes. Where is cell swelling? Where is cell shrinkage? So where do you find inflammation? So in apoptosis, usually you don't find inflammation, right? So how is it cleared? So all these things you have to know pakka. Okay, so these are the questions which are usually asked. Okay, so one more thing is you have to know what is apoptotic blebs, what are apoptotic bodies, and apoptosis. Usually what happens first is apoptosis will cause cell shrinkage. If I can write here, so apoptosis causes cell to shrink. Okay, so this is the first change. So all these changes are seen in your electron microscope or light microscope also. To a certain extent you can only see apoptotic bodies, okay, but all these are changes seen in electron microscopy. So first thing you see is cell shrinkage, next you see chromatin condensation, okay, chromatin condensation, next you see formation of cytoplasmic blebs. So cytoplasmic blebs are formed and these cytoplasmic blebs go on to form surface blebs and these are called as apoptotic blebs, okay, apoptotic bodies. So after all this there is phagocytosis by macrophages, okay, that's why you don't find much of an inflammation, no neutrophils and other inflammatory cells, okay, so these are taken away by macrophage. So this is the question and so this is the option. Correct option was option number B. Moving on to the next question. So your next question you have what are nets? Okay. So let's read the question here. Nets are, okay, let's look at the options. So any doubt in the previous question, students? Any doubt? You can please put it. Okay, so moving on, so the question is nets are, okay, so nets are primary acidophilic granules in the neutrophils, not detected in the blood during sepsis, produced with ROS-dependent activation of an arginine deaminase that converts citrulline to arginines. D. Extracellular fibrillary networks that concentrate antimicrobial substances at sites of infection and trap microbes. So these are the options, okay. So let's read this in detail. So nets are, so the first option is primary eosinophilic granules in the neutrophil. So A, B, C, D. So what do you think the answer is? Okay, so the answer for this question is, so what are nets? First of all, what is net? What is the full form of net? So they are neutrophil. So one second. Okay, so what are nets? So nets are neutrophil extracellular, okay, traps. So neutrophil extracellular traps. Okay. So these, what are these? Are they primary eosinophilic granules in the neutrophils? No, right? So they are not primary eosinophilic granules. Okay. So you haven't heard primary eosinophilic granules. So neutrophils have primary and secondary granules. Okay. So this you need to know what are the primary granules, what are the secondary granules. We cannot discuss everything at length in this class, in this session, but of course when we take individual sessions, all these will be dealt in detail. Okay. So next option, so option A is not right. Let's go to the next option, not detected in the blood during sepsis. So whenever there is neutrophils, whenever there is sepsis, there is neutrophils, and whenever there is neutrophils, there are nets. So it is detected in blood during sepsis. So again, this option also is not right. Okay. Produced with ROS-dependent activation of an arginine deaminase that converts citrulline to arginine. So again, this statement is again false, because arginine deaminase is converting arginine to citrulline, right? So this is again wrong. Okay. So then coming to the option number D. So nets are extracellular fibrillary network that concentrate antimicrobial substances at sites of infection. Yes. So this statement is true. Okay. So what are nets? Okay. So we were talking about nets. So I told you nets are from the neutrophils. So this is the neutrophil. Okay, so neutrophils, please remember that it has primary granules and secondary granules. What are these? Please read. It's important, you should know what is primary and what is secondary. Okay, so now what happens is, so this neutrophils are your first line of defense, right? So this, whenever there is an injury, these are the first cells, inflammatory cells, which will appear. Okay, so also they digest microbes, and how do they do that? By phagocytosis and by hemostasis, right? Okay, so these two important things. Also you have something called as nets, which also helps. So what are these nets? They are extracellular traps. So whenever a microorganism comes, okay, and this ROS is activated, okay, what suddenly happens is the chromatin condenses and the neutrophil itself dies. Okay, and in this process it gives out these material of DNA and histones along with your primary granules, eosinophilic granules, and this extracellular trap is called as nets. Okay, so these traps trap your microbes. Okay, so this is neutrophil extracellular traps. Am I clear? So if we can see, so this is a pictorial representation. Here you can see the neutrophil, and these are the granules. So once there is microorganism, so these are released. So this is your net. Okay, so this is a live image where they have captured a neutrophil, and this is the this green thing is your extracellular traps. All these purple things are microbes. Okay, just to show you that it is extracellular. This is an RBC. Right. So let's move on to the next question. So NETs are important again, so please go through that. So moving on to the next question. So this is a simple giveaway question. So this, whenever there is a needle stick injury, it leads to a small amount of bleeding in a healthy person. Remember, we are talking about a healthy person here. Okay, so read the question carefully. So a healthy person, there is a needle stick injury. Seconds after injury, bleeding stops. Most of the following which of the following mechanism occurs first, and which is most likely to stop arteriolar blood loss from this injury? So what do you think the option is? So, okay. So let's read the option first. So is it because of fibrin polymerization? Is it because of neutrophil chemotaxis? Is it because of platelet aggregation, or is it because of vasoconstriction? What is it because of? So the option here is vasoconstriction, right? So it is option number D. Okay, so this is a basic question where they are asking you about the hemostasis. Okay, so they're just asking you about hemostasis. So you know hemostasis has 4 important. So first and most important is your vasoconstriction. Okay, so this question was based on this. Second is your primary hemostasis. Then you have your secondary hemostasis, and then you have your thrombotic and antithrombotic events, right? So your vasoconstriction, whenever there is a needle stick injury to the arteriole, what is happening? There is sudden, so the endothelial cells are injured. So when the endothelial cells are injured, they release something called as endothelin. Okay, this endothelin is released, and this endothelin is a potent vasoconstrictor. So it constricts the smooth, it acts on the smooth muscles and it causes vasoconstriction, so that this is a protective mechanism, so the blood supply to this area reduces. So that's why the bleeding will stop. So after this there is primary, so wherein you have platelet plug formation, secondary wherein there is fibrin clot, and then this clot gets stabilized and then the clot will undergo resorption. You just cannot leave the clot to stay there, right? So clot resorption will take place. Okay, so this question was, let's go back. So this is a simple question. So the answer here is what? So the question said, which is the first event which occurs? So vasoconstriction is the first event which is occurring. Okay, moving on to the next question. Okay, so here this is a microphotograph and it shows, so this is a microphotograph, it shows a balloon neuron. So this is a neural tissue and it is showing a balloon neuron here with cytoplasmic vacuoles. Okay, which of the following is not true of this storage disease? So which of the following is not true? Any guesses? So which is not true? Okay, so this is a lysosomal storage disease. Yes, this is the so the option over here is option D. So this is not true. So let's look at the options. So option A, this is a lysosomal storage disease. Yes. Did you guys guess what disease am I talking about? This is Tay-Sachs disease. So whenever we see ballooned neuron, remember this is Tay-Sachs disease that they are talking about. Okay, Tay-Sachs disease. And what do you see? So under the electron microscope, you see rolled configurations of lysosomes. Yes, because this is a lysosomal storage disorder. In Tay-Sachs disease, you see rolled lysosomal configuration. So this option is also correct. Cherry red spots appears in the macula. Yes, this is also a correct statement. So in Tay-Sachs disease, you see cherry red spots in the macula. Remember, cherry red spots in the macula occur because of many other conditions. It is not pathognomic for Tay-Sachs. So your CRAO is one very important condition. Okay, so it is not pathognomic, but yes, it occurs in Tay-Sachs. Okay, so now it is because of beta galactosidase deficiency. So this particular statement is wrong. It is because of hexosaminidase alpha subunit deficiency. Okay, so this was a direct question again. Why I have put this question? Because your storage disorders are very important. Okay, your storage disorders, you have glycogen storage disorders and you have your lysosomal storage disorders, right? So most important, please read about Tay-Sachs, Gaucher's, Niemann-Pick's, okay, Sandoff. So all these things. And what is important here is there is some enzyme deficiency. So whenever there is some enzyme which is deficient, it results in accumulation of toxic products inside the cells, okay, toxic metabolites. So what accumulates in Tay-Sachs is your GM2 gangliosides, okay, so this accumulates here. So you need to know what is the toxic metabolite also. So what is the enzyme, whenever you talk about storage deficiency, what is the enzyme deficiency and what is the metabolite which is accumulated, okay. So Tay-Sachs disease, let me just quickly run through. So this is a very deadly disease, occurs in infants, okay, because of this enzyme deficiency. They don't live for more than 2 years, okay, they present. So initially the clinical feature is very confusing. So they progress, they have a lot of neurodegenerative issues, okay, and by 2 to 3 years, it results in mortality if it's undetected. Okay. Classically, balloon neurons which are seen, this is because of your storage of these lysosomal products, right? So let's move on to the next question. Okay. Again, this is an important question. Okay, this is a very recent onset and recent topic. So which is false with respect to IgG4 related disease? Okay, which of the following is false? It is an autoimmune disorder. B, IgG4 antibody is produced by plasma cells. C, they have a high serum IgG4 levels. Fibrosis is not seen in the affected organs. So which is false? So this option number D is false. Okay, fibrosis is seen in IgG4 related disease. Now what is IgG4 related disease? Now this is a newly described entity. Okay, somewhere around 2008 this was described. So a lot of autoimmune disorders, like you have your Mikulic's disease, you have Riddle's thyroiditis. So all these things are put under this now. Okay, so some school of thought say that all these things come under this. Now this again is one of the favorite questions of the examiners lately. So this is a autoimmune disease, and what you see, it's also called as a fibro-inflammatory disorder. And it's a very confusing presentation. They almost involve all the organs of the body, be it your lymph node, be it heart, be it orbit, lacrimal gland, your salivary glands, your pancreas, kidneys. So everything is involved. Okay, so they are a multi-system disorder, and they present like a tumorous condition. Okay, it's almost always confused for a non-Hodgkin's lymphoma. Okay, so the presentation is like that, and the patient is also extremely sick. Right, so let's move on to the options. This is an autoimmune disorder. Yes, it is. IgG4 antibody is produced by plasma cells. Yes, so antibodies are produced by plasma cells, and this is what is raised in this patient. So if you take the blood of these patients, they usually have a high serum IgG4 level. So this option is also correct. Fibrosis is not seen in the affected organ. So now this particular option is wrong. It is seen. So I told you the hallmark is fibrosis. It's a fibro-inflammatory disorder. Apart from fibrosis, what do you see? You see lymphocytes and you see plasma cells. Okay. Sometimes they form lymphoid follicles. Okay. Another thing is the vessels. They undergo obliteration with these inflammatory cells. So this is obliterative phlebitis. So obliterative phlebitis is also seen here. Okay. So these are the three things which is usually seen in a biopsy of IgG4 disease. So this is just to show you. Okay, this is a lymph node, and you can see the lymphoid follicles here. But what are these pink lines and pink spaces? So this is fibrosis. Okay. So a lot of fibrosis is occurred. Okay, this is IgG4 related disease I'm talking about. Almost all the organs, it's a multi-system disorder. What are you seeing here? It's a vessel which has gone obliterative phlebitis. Here you're seeing lymph. This is a low power view, but all these blue dots are your lymphocytes and plasma cells. And what is this? This is your IHC. Okay, immunohistochemistry. These brown things, they are nothing but your IgG4 positive plasma cells. Okay, and if you do serum levels of this, it's usually more than 135 milligrams per deciliter. So anything more than this is considered significant. Why is this important? Why cannot we just let this to be like a simple autoimmune inflammatory disorder? Why you need to identify? Because these disorders will not respond to your regular steroids. Okay, they need to be treated with something aggressive. They need immunomodulation on long term, because as soon as steroids are stopped, they recur. Okay, so immunomodulation is required by methotrexate, rituximab, so all these drugs. So that's the reason. And one more reason is these disorders long term, they progress to B cell lymphomas. Okay, so that is why these have to be identified and treatment should be appropriate. Let's move on to the next question now. Again, this is a giveaway question. So this is a 10-year-old child with xeroderma pigmentosum. Okay, he is presenting with a lesion on the face, and a biopsy has been taken. So this is what is seen in the biopsy. Okay, so what is your diagnosis? Option A, squamous cell carcinoma, B, basal cell carcinoma, C, Merkel cell, and D, malignant melanoma. So now all these are your cutaneous malignancy. So what do you think the option is? It is easy. Yes. So the option here is A, squamous cell carcinoma. Okay, so what are you seeing here? You are seeing squamous eddies, okay, or squamous pearls. So all these things, they are your squamous eddies or your squamous pearls, okay, or your keratin pearls. Keratin pearls. Okay, so this is squamous cell carcinoma. Oh, so what is xeroderma pigmentosum? It's a genetic disorder wherein there is impaired DNA repair. Okay, so now whenever there is impaired DNA repair, when they are exposed to UV radiations, they are more prone to develop cutaneous malignancies. Okay, so that is why this question said it's a child with XP. Okay, it's a child with XP. What is the mode of inheritance of XP? You should also know the mode of inheritance. It's autosomal recessive. Okay, so there is defective DNA repair, and this leads to cutaneous malignancy. So what is occurring in this child? This photograph here, basal cell carcinoma can also occur, but here this photograph is of squamous cell carcinoma. Okay, so that is what they are seeing. So let's move on to the other carcinoma, what we can see. So if we move on to the next carcinoma, just to show you, they can give you microphotographs. Now you have picture-based questions in your exams. So basal cell carcinomas, so this is occurring from the epidermal cells, and what are you seeing here? These are tumor islands here, okay? And how do they occur, these tumor islands? You have peripheral palisading of the tumor cells. So this is very important, and high NC ratio, okay? One more important thing, what you're seeing here, you're seeing an empty space around the cell, right? So this is peritumoral clefting or retraction cleft. So very classical of retraction clefts, again very classical of BCC, okay? So you see retraction clefts in basal cell carcinoma. Then what are you seeing in the stroma here? These blue dots are of course your inflammatory cells, but what is this bluish hue here? Myxoid stroma, okay? So sometimes even intracytoplasmic mucin pools are also seen. So this basal cell carcinoma, you need to know they appear like this, nodules with peripheral palisading and cells here with a myxoid stroma. Okay, so here this is a microphotograph. Peritumoral clefting is not appreciated much, but can you see this? This is your palisading. Okay, so this is basal cell carcinoma. Next, the other two options were Merkel cell carcinoma and malignant melanoma. Merkel cell carcinoma, again, it's a cutaneous malignancy. And what are you seeing here? You are seeing these round blue cells. Okay, it's a small blue round cell tumor. It's a neuroendocrine tumor. So classically, what you're seeing is salt and pepper condensed chromatin. Okay, there's no prominent nucleoli over here in these cells. Can you see these blue dots over here it's highly mitotic and pleomorphic. So that is why all these blue dots are there. These are mitotic figures. Okay, so it is a very it has a bad prognosis, right? So it is an aggressive form of carcinoma. Okay, and there is no conspicuous nucleoli, and you find this salt and pepper appearance of the cell. Okay, now moving on to the next one, malignant melanoma. So what do you see in malignant melanoma? You see it's a cutaneous malignancy again arising from the melanocytes, and you are seeing some pigments here, these brown pigments, and very classically you will see prominent nucleoli in the cells. Okay, so this is malignant melanoma. Okay, so if all these image based questions appear, you should know and identify them. Let's move on to the next question. Now this is a 35-year-old man, and during routine annual health checkup, so this is a routine annual health checkup, okay? He is found to have bilateral hilar lymphadenopathy. On further evaluation, he had raised serum ACE levels and cervical lymphadenopathy. Which of the following is not correct about this disease? Lung is a common site of involvement. Lymph node of the biopsy shows non-caseating granulomatous lesion with giant cells. Asteroid bodies are seen only in this disease. Schumann's body is an example of dystrophic calcification. So which option is not correct? So option number C. So what disease are we talking about? First of all, we are talking about sarcoidosis, right? So we are talking about sarcoidosis. What are the giveaway points for sarcoidosis? One, he is found to have bilateral hilar lymphadenopathy, and he is asymptomatic, okay? And he has raised ACE and he has lymphadenopathy. So all these things point towards sarcoidosis. Lung is the most common involved organ. Yes, this is true. Biopsy shows non-caseating granulomatous lesion. Yes, this is a UG thing you have been learning. Non-caseous granulomas are seen in sarcoidosis, whereas caseous granulomas you're seeing in TB, right? So other causes of non-caseating granulomas also you should know, like your Crohn's, other things, okay? Now, asteroid bodies are seen. So this particular, in the multinucleated giant cell, what you see, this stellate thing is your asteroid body, okay? So this is seen only in this disease? No, this is false, okay? Asteroid body can be seen in many other diseases, including TB, including sporotrichosis. So many conditions you would see asteroid body. So this is not pathognomic for this disease, okay? Schumann's body is an example of dystrophic calcification. Yes, this is also true. So the answer over here was asteroid body is seen only in sarcoid. So that option was wrong. So if you see, this is just the gist about sarcoidosis. It's a multi-system chronic inflammatory disease with lung involvement is most common. You find non-caseous granulomas with giant cells, okay, and you find asteroid bodies and Schumann bodies, okay, and there is bilateral lymphadenopathy. So these are the other associations. So that also you have to know. Okay, let's move on to the next question. Triad of acute necrotizing granulomas in the respiratory tract, focal necrotizing or granulomatous vasculitis, focal or diffuse necrotizing crescentic glomerulonephritis is seen in. So, is it seen in Kawasaki's, Stokes-Strauss syndrome, Wegener's, Takayasu? So, where do you see this? So, the correct answer here is Wegener's granulomatosis. Okay. So, again, you have to know what Wegener's granulomatosis is. So, there is respiratory involvement. Okay. It's a vasculitis. So, you need to know what are your large vessel vasculitis, medium vessel vasculitis and small vessel vasculitis. Give more importance here because many questions are asked from this. What are the so what is associated with it? What are the markers which is seen? And you see necrotizing vasculitis. Okay, so you see necrotizing vasculitis. So the cell wall of the vessels, okay, the small vessels are, you have a little or lot of inflammatory cells. So that is inflammation of the small vessels. So this is Wegener's, okay, and you have crescentic glomerulonephritis in the kidney. So that is also, so this is the triad. So this is seen in Wegener's granulomatosis. Okay, let's move on to the next question. So now this is a 45-year-old male. Okay, so now this 45-year-old male is presenting with pain abdomen and on endoscopy a tumor was found. Okay, histopathology of the tumor shows spindle cell like this, and this tumor is positive for a marker. So what is the marker? Is this CD117. Okay, and which of the following is not true about this tumor? So which is not true? So you have to identify the false statement. So let's look at the options. Mutation of KIT or PDGFRA is seen. DOG1 is considered as the most specific marker. The tumor is always composed of spindle cells. Option D, origin of tumor is now recognized to arise from the interstitial cells of Kajal. So here they are asking you which is not true, which is the false statement. Okay, mutation of KIT or PDGFRA is seen. Yes, this is a correct statement. DOG1 is considered as the most specific marker. Yes, they are positive for CD117, but the mutation, you also see this marker DOG1. Okay, next, the tumor is always composed of spindle cell. Now, this particular statement is false. Now, whatever tumor is seen over here, first of all, this I forgot to mention what this tumor is. We are talking about GIST here. Okay, students, so this is a gastrointestinal stromal tumor. Okay, so this particular tumor is positive for CD117. Okay, so your tumor is always composed of spindle cells. So now when it comes to GIST, not just spindle cell but also epithelioid cells are also seen. Okay, so it can be spindle or it can be epithelioid as well. So option number C, which is saying it is always composed of spindle cell, is wrong. Option D, the origin of the tumor is from interstitial cells of Kajal. This particular option is correct. Okay, they are seen in stomach and intestines as well. Okay, so this is gastrointestinal stromal tumor and it is a spindle cell tumor. Okay, so points about GIST is it is a spindle cell tumor, but not just spindle cell, you will also see epithelioid cells. Okay, your CD117 is your marker. Okay, they arise from interstitial cells of Kajal. This is important. They arise from interstitial cells of Kajal. And your mutations. Okay, what are your mutations seen? That is also important. Okay, and one more very important thing is that dog 1. Okay, this is a specific mark. Right, so this is about few important points about GIST. Okay, so moving on to the next question. This is a 23-year-old woman. She has suddenly noticed a bloody brownish vaginal discharge. On examination, there is a 3 centimeter mass in the lateral wall of the vagina, which is felt in the lateral wall of the vagina. Okay, laboratory study shows that her serum HCG levels is markedly elevated, and a biopsy specimen of the vaginal mass is obtained and it is shown. Okay, so this is the biopsy microphotograph. Which of the following cells are most likely to be present in this lesion? Okay, so what can you see here? So this is a female, 23-year-old female who is presenting with a mass, and this is the biopsy. Any guesses? So what could be the answer? So the right answer for this question is D. Okay, so here we are talking about choriocarcinoma, right? Choriocarcinoma is the diagnosis. Okay, so what should you know about choriocarcinoma? Right, so this choriocarcinoma occurs from your trophoblastic cells, and this is a syncytial trophoblast. Okay, so you can see a lot of these cells, and you can see a lot of necrosis and hemorrhage. So this is classical of this. Commonly occurs in reproductive age group. Okay, and it is highly chemosensitive. Okay, you have, so the one of the drug is your methotrexate. Okay, and so that is one more thing you need to know. And also you need to know that these patients have elevated serum HCG levels, and in fact serum HCG levels are also used for prognosis. Okay, that's here. Choriocarcinoma is what we are talking about. Occurs in the reproductive age group. Okay, occurs in the uterus, in the ovary, fallopian tubes, also in the placenta. Okay, there will be a preceding non-molar pregnancy sometimes, and it is also occurs with a complete hydatiform mold. So all these are risk factors. And what are you seeing? Raised beta unit HCG. Okay, so this is what is usually seen. So now these, whenever you come to ovarian tumors, right? So ovarian tumors again are very important, and you need to know what tumors and what are the markers, tumor markers, right? So your yolk sac tumor, you have your alpha fetoprotein. Okay, so alpha fetoprotein is usually seen in yolk sac tumor. So this is also something that you need to know. Okay, so then next, so that is one very important thing. So here already we read about beta HCG. So beta HCG is raised in choriocarcinomas. So next you need to know where LDH is raised. LDH is raised in dysderminomas. You also need to know where CA125 is raised. Okay, all these are with respect to ovarian carcinoma. So CA125 is raised in epithelial, so surface epithelial carcinomas of the ovary. Okay, so this present with raised CA125, and where inhibin is raised. So inhibin is a marker for your granulosa cell tumor. So this is again very important, right? So your alpha fetoprotein is raised in yolk sac. So beta HCG is raised in chorio. LDH is raised in dysderminomas. CA125 levels, inhibin is granulosa cell tumor. Now, one more very important thing is your Sheller-Dover bodies and your call exner bodies. So all these things also you should have clarity. So where is it seen? In yolk sac tumors. And where is this seen? Call exner bodies. So these are seen coffee bean. Okay. So this is where is call exner body seen? In granulosa cell tumor. So again, these are exam questions. So I'm just introducing you, not going in detail. So please read about all of this. Okay. So you should be pakka. So this is like a revision class. Okay. Next, we'll move on to the next question. So the next question is, microvesicular steatosis is characteristic feature of neonatal hepatitis, Reye's syndrome, alpha-1 antitrypsin deficiency, primary sclerosing cholangitis. So what is the correct answer here, students? The correct answer here is Reye's syndrome. Okay, this is a non-alcoholic steatohepatitis. Okay. So what is happening? So first let's know what this means. Okay. So here if you see in the hepatocytes, you see these tiny vacuoles, right? So these are microvesicular steatosis. Okay. So if you are seeing these outside, this is macrovesicular steatosis, commonly seen in alcoholic liver disease. Okay. So when you do a biopsy of the liver, this is what is seen in the hepatocytes, and this is usually seen in non-alcoholic, and here in the options you had Reye's syndrome. Okay, again, what is Reye's syndrome? I hope all of you know. Okay, what is this? This is a fulminant hepatitis kind of a picture with encephalopathy. Okay, usually after viral infections, right? So post viral infections we usually see this, and the children usually present with nausea, vomiting and letharginess, disorientation. So all this is seen, and also it is seen to be associated with salicylate. Okay, so excess salicylates also cause this syndrome. Right, so what do you see in neonatal hepatitis? You see a lot of ballooning and many non-specific changes. What do you see in alpha-1 antitrypsin deficiency? Here again you see something very similar to microvesicular steatosis, but what we are seeing in the biopsy is eosinophilic globules. Eosinophilic globules are seen in the hepatocytes. Okay, so if they are asking you some case scenario wherein they are mentioning eosinophilic globules are seen in the hepatocytes, when they are talking about alpha-1 antitrypsin deficiency. Again, around the bile ducts, if they are telling you there is onion skin fibrosis around the bile ducts, then this is seen in primary sclerosing cholangitis. Okay, so here the question was, where is microvesicular steatosis seen, and the correct option is option number B, Reye's syndrome. Okay. Let's move on to the next question. So this will be our last question of the day. Okay. So lipidic pattern of growth is seen in. So this is a very easy question. Small cell carcinomas of the lung, adenocarcinoma of the lung, lung carcinoid, oat cell carcinoma. So what is the correct answer? So the correct answer is your lipidic adenocarcinoma or your adenocarcinoma lung. Okay. So some people might say there is a little discrepancy in this option. Yes, because now, so this is the lipidic pattern. So this is a micro photograph which is showing lipidic pattern. So what can you see? Normal alveoli, and this carcinoma has grown around this alveoli. Okay, so this area is carcinomatous here. So this is lipidic pattern. Okay, lipidic pattern. Okay, and why? So in 2015 there was a new WHO classification which came. So the earlier terminology of bronchoalveolar carcinoma was taken out, and they have put it as adenocarcinoma, minimally invasive, non-mucinous, mucinous, okay, lipidic. So these are the types. Okay, again you have squamous cell carcinomas, where you have keratinizing squamous cell carcinomas and non-keratinizing squamous cell carcinomas. Okay, you have lung carcinoids, again carcinoids of the lung. So all these things are a brief outline. So you should go back and you should be thorough with the recent classification of lung tumors. Okay, so this is again important. So let's go back to our question. So where was this pattern seen? So small cell carcinoma of the lung, no. Lung carcinoid, no. It's a neuroendocrine carcinoma, so you don't find this pattern. Oat cell carcinoma is again small cell carcinoma, so this is also no. So adenocarcinoma lung is the correct answer. Okay. So this is the pattern which is seen. So I think we'll end here. So for the day, for this live session, so we've done 12 questions. So any doubts, you can please put it up on the chat box so I can actually see. Okay, so these were the 12 important questions. Okay, so I think okay, so I think we can end now. So we'll meet you again. So I'll meet all of you again in the next part 2 of this